Welcome everybody, and thank you for joining today's session, New Medications for Kidney Patients. My name is Lydia Lauder and I'm the National Director of Programs and Public Policy with the Kidney Foundation of Canada. I'll be serving as your moderator today. In this session, we'll be discussing some exciting developments in the area of medications for kidney patients and how to speak with your healthcare team about what might be available for you. And now it gives me great pleasure to introduce you to our speakers, Lisa Hun, Dan Martinson, and Dr. Adira Levin. Lisa is a long-time kidney patient and volunteer. She had a first living donor kidney transplant from her mother Josie in 1995, which unfortunately failed. In 1997, Lisa had her second kidney and first pancreas transplant from a deceased donor. In 2008, she received another pancreas transplant. For the last 25 years, her transplanted kidney has been going strong. Lisa has experience in in-center hemodialysis and peritoneal dialysis, and is also a type 1 diabetic on an insulin pump. She enjoys sharing her kidney disease experiences with her peers through the Kidney Connects peer support program, along with being a dedicated support group facilitator. Dan Martinson graduated from UBC with a Bachelor of Pharmacy and subsequently completed a hospital residency and postgraduate Doctor of Pharmacy from the University of Washington. He has been practicing in clinical nephrology for 25 years with a number of publications and has written a chapter in the clinical pharmacy textbook. Dan has been involved in numerous projects over the years, resulting in a number of awards. He has served as Chair of Pharmacy Services and Formulary Committee for BC Renal for over 20 years, with a secondment as Director of Pharmacy for BC Renal. He is also a Fellow of the Canadian Society of Hospital Pharmacists. Dr. Levin is a Professor of Medicine, Head of Division of Nephrology at the University of British Columbia, and Consultant Nephrologist at Providence Healthcare St. Paul's Hospital in Vancouver, Canada. She is the Executive Director of the BC Renal Agency, which oversees the care, planning and budgets for kidney services in the province of British Columbia. She is active in international activities across the spectrum of kidney and has served in leadership roles at the International Society of Nephrology, most recently as President between 2015 and 2017. She was also one of the founding members of the Declaration of Istanbul Custodian Group and served as one of the first co-chairs of that group. She's been active in both ISN and DICG concerning advocacy for patient rights for equitable access to care and in the prevention of exploitation of vulnerable populations. Dr. Levin's major research interests include non-traditional risk factors for cardiovascular disease in CKD patients and progression of CKD variability, as well as models of care. She has over 600 peer-reviewed publications and numerous book chapters. She's the principal investigator on a large SPORE network, CanSolve CKD, focusing on patient-orientated research. She collaborates with investigators across Canada and internationally. She's received numerous teaching and research awards from the Canadian Society of Nephrology, the Kidney Foundation of Canada, British Columbia Health Research Institute, and was inducted as a Fellow into the Canadian Academy of Health Sciences. And for her contributions to the life of Canadians, she was awarded the highest civilian honour, the Order of Canada, in 2015. And now I'd like to invite Lisa to begin.
Hi, everybody. My name is Lisa. I am so excited to be asked to speak on living your best life because that is sort of the motto that I live by. So I live each day with a positive attitude and live it to the fullest. So I'm just going to share a little bit about my story and some of the medications and things that have changed along the way. So I was first diagnosed as a diabetic many years ago when I was 4 years old. I'm a little bit older now, as you can all tell. And at that time, they basically told me, you know, you're going to have kidney disease and you're going to have this wrong with you and heart disease and all kinds of other things. And being a type 1 and being on insulin and having to control your blood sugars constantly, that was never in the back of my mind. 1995 came along and the doctor said to me, you know, you need to look for either a living related transplant or we have to put you on the deceased or you have to go on, well, you will need to go on dialysis if you go on the deceased list. And I'm like, what is all this about? I never knew anything about kidney disease or what it entailed. Boy, was that a learning curve for me. I did go on hemodialysis to be strong enough to receive a kidney from my mom that unfortunately failed. Along the way, I actually did start on anti-rejection medication, cyclosporin, before the transplant. This was something that they did to get your body used to the medication, so the side effects would not be as strong. I was only on generally for about 6 weeks, so the medication really just started to work and really did not have a chance to give me any of those lovely side effects we all are aware of, being nauseated, upset stomach, hair growth and things like that. So that was a little bit. I went on to do peritoneal dialysis, and I did that approximately for 1 year, being on all kinds of medications from heavy dosages of prednisone. We used to go on very high dosages of prednisone once we had the transplant, and we're tapered off accordingly over the years. I now, after many years, sit at doing 5 milligrams per day, but as Lydia said at the beginning, I've had a kidney transplant almost 26 years this May. So it's been constant changes along the way. And just a piece of advice that I would say to people who are new to the kidney journey, new to medications, just follow the advice of your doctor. It's very, very important. It's very important not to forget these medications, and it's very important to understand your blood work and be able to work with your doctor to make changes accordingly. So I just want to say the cyclosporin, when I first went on, it used to be a huge, okay, I'm not going to be doing this well, a huge, huge tablet. And we used to nickname it a pig pill. And it was so hard to swallow. You had to put it on the back of your throat and take all the water just to even get it down. But if you look at it, without that pill, your kidney was going to fail. And I wouldn't want that to happen. So you made it happen, and you made it happen twice a day. So things changed over the years. I had my second transplant, and medication changed. Blood pressure medication changed. It improved. Some of the blood pressure medications that I were on affected my liver. So we always had to watch my liver functions, making sure that I was on the right blood to both protect my kidney and to protect my heart as well. So over the years, medication has changed in one other way that I find is very, very important. We went from this big, large pill to a pill called Prograf, and we used to take them. They used to be just ordinary little pills, and we used to take that twice a day and approximately every 12 hours. So in the last few years, I don't know, my memory's not good with years and numbers, and I'm sure the pharmacist and doctor can correct me on this. We went to Atigraph, which is probably the biggest change, where you take it once a day, and with that particular medication, you don't have to remember it until the next morning. So where was I there? Okay, so I had a pancreas and a kidney transplant, and unfortunately my pancreas has failed. But I also feel that with the pancreas and kidney transplant, though you have to take a lot of medications, and though there are a lot of side effects, and though things change, I think it's very important to realize that you need to live your life, and things will happen, and deal with those things on a daily basis. Don't worry about what's going to necessarily happen in the future. So I just want to leave that closing thought with you.
Thanks so much, Lisa. Thank you so much for sharing your story. I'm going to hand it over now to Dr. Levin and Dan to continue with the presentation.
Great. Thank you, Lisa, for helping us contextualize all of this. It's always nice to recall what was and what is and how things have evolved. So thank you very much for inviting myself and Dr. Martin Newson to this panel discussion, Living Your Best Life with Kidney Disease, a discussion about care and medicines. What we're going to do is help the audience understand best care models for kidney disease and discuss some new medications that are designed to help people delay the progression of kidney disease, reduce symptoms of heart failure and hospitalizations, address some lab abnormalities, and address some symptoms. And so I think it's really interesting at this point in time to have this array of medicines that can do all these things that really do help you live your best life. And also we want to make sure that we remind or help people to speak best with their doctor about how to access these and other medications that will soon be very widely available to all of us, and we're very excited about that. Let's start with the patient in the middle, because our best model of care is with the patient at the center, with all of their care team members around them, their primary care physician, but importantly, the dietitian, nurse manager, the people that you go to the laboratory to get your tests from, and your pharmacies, the counselors, the specialty physician, and obviously your hospital team when and if you need them. The important components of kidney programs should be that you have a longitudinal follow-up by a trained team of individuals, and I've listed them here. And there's a reason that we do regular testing of the lab and regular clinic visits, and that's so that we can pay attention to all of you, learn a lot about you and your wishes and goals, as well as you learn about the team and feel comfortable with them. We can pay attention then to heart and kidney problems, since they can exist together. And we can help to remind people and ensure that they subscribe to a vaccination program and a good education program where you really get the tools around how best to manage yourself, as you heard from Lisa's story. Know as much information as possible about diet, medication, exercise, smoking cessation, all your different options should you need them, dialysis, transplant, and also conservative care. We delay progression of kidney disease in a total way, that is by controlling and trying to address a number of things like blood pressure, and that's where controlling your weight, salt and water intake is important. Your glycemic and metabolic control, whether you're diabetic or not, these are very important. And then there are a number of different drug therapies, which we'll talk about later, in terms of lowering the protein in the urine, which we know is important, and the newer agents, which we'll talk about in detail. The team, as I said, is very important. It's intended to be a wraparound team. This is the best model of care that we know. And again, the regular blood work and urine testing to make sure that things are going in the right direction. And as I always say, the real purpose of our kidney care clinics are to educate us about you and you about your condition and the team, to navigate the system and to make sure that we have good surveillance of you as a person and all your wishes and desires, so that we can help to navigate that system. So it's pretty exciting in nephrology right now when it comes to medications, and that's what our section is about. And there is a changing landscape. There was a time where oncology and renal diseases were very far apart, and that ultimately now we have a new era in medicines for kidney disease, where we can show you the increasing number of medicines that are available for kidney disease, which is really quite fantastic. And so now in the last few years, where really the publications as well as the medicines are increasing, and we're very excited to be in this space now, because we spent the last 20 years, Dan and I, wishing that we had other medicines to give you to help you with your kidney diseases and all its attendant problems. And so this is a bit of a timeline showing you that these are the usual medicines, the cholesterol lowering and angiotensin receptor blockers like that you've been on in the past. And there was a big gap between 2000 and about 2017 when tolvaptan came on the scene. That's for people with polycystic kidney disease. And now we have really more and more medications, and that's what's so exciting. There are many studies that are either going on, recently stopped, and there are many things that have newly been approved. And Dr. Martinussen will go into that much more detail, but I think it's nice to have a list this long and see the names of the different studies and the things that are going to be available to you, especially with early kidney disease. And so the new medications that we wanted to spend some time talking about are the SGLT2 inhibitors, which we call the flozins, and that's Cana, Dapa, and empagliflozin. There's an group called mineralocorticoid receptor antagonists, which is a mouthful for us, so we just say MRAs. They also delay progression. There are new potassium binders, there are new phosphate binders, and there are new medicines for itch. And that's a pretty big list, and I think that will give Dr. Martinussen a lot to talk about. So the flozins, as I said, are EMPA, CANA, and DAPA. And there are many, many studies, both in people with diabetes, as indicated with this, some with endpoints of kidney disease to see if we can delay progression, and some with endpoints of heart disease, and some with combinations. And this just gives you a sense of how busy many of you as patients enrolling in these studies, but the investigators as well around the world have been trying to really look at the important outcomes for patients and for the healthcare system, which is preventing kidney disease, preventing heart disease, preventing hospitalizations, preventing death with these flozin medications. And they show benefit in a very, very large number of patients. And the flozins do a number of things. For people with type 2 diabetes, they help to control the blood sugar, they improve heart outcomes, and they delay the progression of kidney disease. That's if you don't have a kidney problem. If you actually have kidney disease, they also improve the heart outcomes, delay progression, and they lower your blood pressure, reduce your weight, and reduce other things like uric acid, which might cause gout symptoms. And if you have heart failure, it improves heart outcomes, keeps you out of hospital, delays progression of kidney disease, and does the same thing. So these are really quite amazing new medications. And so with that, what I'd like to do is to hand it over to Dr. Martinussen so that he can tell you about more detail about the drug therapies and also how drugs are approved in Canada to get them to you. So Dan, with that, I'll hand it over to you.
Thanks for that introduction, Adira, to where we are, and it's all quite exciting. And for Adira and myself and others, reading all these studies over the years, where it's sort of hurry up and wait. We'd really want to provide these therapies to our patients to improve outcomes. But I wanted to start out just by sort of setting the table of how drugs actually get approved in Canada. And so industry, the folks who innovate and produce these medications, will submit a product to Health Canada for review. And that takes a period of time for that review to happen. So that's the regulator in red. And then if they give the notice of compliance, or NOC, and assign it a drug identification number, a DIN number, then the next step is for the National Health Technology Assessment, which is CADAS in the center blue, or Canadian Drugs and Therapies Assessment Group, undergoes what they call a Common Drug Review, or CDR. And that takes a period of time. And they will review all the literature and come up with a recommendation. And the recommendation would be to either list the drug, in other words, it has benefit, or they would have not list it, or may have some caveats. And after that step, no pharmacare in the country will look at the drug until that step is reviewed. And then the provincial payers, they will take a look and engage in what's called the Pan-Canadian Pharmaceutical Alliance negotiation to arrive at a price that they agree upon. So you can see from start to finish, there can be some lag of time. And again, for those of us that are involved looking at the trials and we know the benefit, we'd certainly like to provide that medication sooner to you, but that's the landscape. So as Adira said, the SGLT2 inhibitors, DAPA, EMPA, and canagliflozin, they do show good evidence to slow the progression of kidney disease. They're well tolerated. There's some additional benefit with diabetes. There's good evidence to slow heart failure. There's an additional benefit to the drugs known as ACE inhibitors, or ARBs. So this would be drugs like ramipril or candesartan. And then DAPA will actually soon become generic in Canada, and that will improve equitable access. So it's not only about getting a drug covered, but in private plans, but it's to improve access for all who need it. And unfortunately, the manufacturer did not apply to CADTH, that review body, for chronic kidney disease, that indication. So that sort of was a bit of the fly in the ointment to delay getting this approved. So all that said, we believe it represents good value to the patient, the private and public payers. And so we believe that it will become likely the standard of care shortly in Canada to delay the progression of kidney failure. The next drug is finerenone, which is a mineralocorticoid receptor antagonist, or we just say MRA. There's good evidence that it also delays progression of kidney disease, and I can't underscore the importance of this. You know, the ACE and ARBs, we've had those for 2 decades now, and this is the next phase where we can offer something to provide additional benefit, additional delay in progression of kidney disease. Unfortunately, because it is a new drug and by an innovator, it will be some time before it goes generic in Canada. Seems to be well tolerated by patients and likely is an additional benefit to both DAPA and the ACE-ARBs, but certainly to the ACE-ARBs. And additional trials may be needed to determine the additional benefit to DAPA or empagliflozin. And it may become the standard of care such that patients may be on both an ACE or an ARB, the SGLT2 like DAPA, and with finerenone. The CADTH review is not yet complete, so it gives you an idea where we are in the provincial landscape of funding it. And cost may be a barrier initially, but it's still under review who will fund it. Then the newer potassium binding agents. The first one is a bit of a mouthful: sodium, zirconium, cyclosilicate, and the next one is patiromer. Both agents work to bind potassium in the gut to reduce serum potassium, which is sometimes required in advanced kidney disease. There's good evidence of effectiveness. 2 older agents also do this. They are currently the standard of care, but they have less evidence of effectiveness. So we have this funny situation where the newer drugs, they obviously have to undergo more rigorous testing to demonstrate effectiveness, but we're using older agents that don't have that same level of evidence. But the newer agents represent a substantial cost increase in care, and the public payers so far have not been able to justify the funding of those 2 drugs. CADTH, the review technology review folks, recommend patiromer under certain conditions, but with a much reduced price, and it so far has not recommended sodium zirconium cyclosilicate. So at some point in the future, either or both of these agents may become standard of care should pricing improve. The next one is the iron-based phosphate binders. So just below, you see the various phosphate binders starting in the 1970s with aluminum-based binders, but they actually could be linked to anemia, cognitive disorders, and osteomalacia, bone disorder. So we generally don't use those anymore or for a limited time. And then we have magnesium-based binders, but they can cause diarrhea and too much magnesium in the bloodstream or hypermagnesia. And then lanthanum carbonate, the calcium-based binders came along as well. There is some evidence of vascular calcification or arterial stiffness, but that is not definitive, I think. So we are cautious with those, but they are the standard of care. And if there is evidence of that or a higher serum calcium, we can move to what we call the non-calcium-based binders, sevelamer or lanthanum. And they came along more recently, but you can see there's a number of bowel issues with those. Finally, we have the iron-based binders, and in Canada, we have sucroferric oxyhydroxide, which recently came to market. But it is more expensive than current options, and it is effective in lowering phosphorus compared to no treatment, but comparable to the phosphate binders we do use. it may cause higher GI side effects. And for Cadith, they suggested that the cost should not exceed the least costly non-calcium-based binder, which is lanthanum or sevelamer in this case. So that's a bit of a challenge to get to that point. And here's the newest kid on the block. This is a drug for itch, or what we say is pruritus. It's difelikefalin, and it's indicated for moderate to severe itch in adult dialysis patients. So a pretty narrow band of people who would use it. And it is related to an opioid. It's a highly selective kappa opioid receptor. It's an agonist of that receptor, so it stimulates it, and it's injected after dialysis. There's limited clinical trial data, but it suggests about a doubling of improvement in itch compared to placebo, so it may not completely alleviate it, but it would help. There are some side effects, mild ones, diarrhea, dizziness, vomiting, so that may have something to do with dose. And more severe is what we'd be looking for, too much potassium in the blood or hyperkalemia. And you can see those others there, which we would adjust dose or be looking for. Now, the current cost is weight-based, but it's about $4,500 Canadian per patient year. And that cost vastly exceeds the current treatment options, which the point may be moot, because if somebody has severe itch and have tried those other options and they don't work, then we may be left with this. It's currently under review by Cadith. It is not yet reviewed by provincial payers. So again, at some point in the future, this could become a useful agent in patients with severe itch, not relieved by current therapies. Interesting, an oral version of this drug is being developed with a different indication, but that will be following that as well. So what are the principles for funding or improving access? Well, we certainly, I think, can all agree we want evidence-based evaluation demonstrating benefit exceeding risk. We'd like for equitable access, so the patients who need the new medication can access it, and that there's value to both the patient, the payer, and to the public. In other words, simply, is it worth it? So that's what all the evaluation goes into these. And so new therapies into the future, unfortunately, chronic kidney disease is growing worldwide, and drug companies are taking note of that. So more medicines will be researched and brought to market. And with each one, evaluations will determine if the advantages will be worth the price. Sometimes new medications will be used, but under certain conditions to ensure optimal use, so the right patients are getting the right drug at the right time. And kidney disease research and innovation is currently enjoying a variety of new treatment options to explore. And that's really an exciting time, because we haven't had this, as I say, in the last 20 odd years, new innovations. So we're excited to delay kidney disease progression, and that will revolutionize therapy going into the future. So we're very excited about that. And I just want to point out that you may hear that a new medicine in the media, but it may still be years away from incorporating into daily practice, because it has to go through all that review in Canada, and payment issues may be an issue. So we have to work through that in the system. So unfortunately, unless you have deep pockets, you may have to wait to get these medications covered. I just want to touch on, making the best use of the medicines you have now, and really to know your medication, the name, the dose, the schedule, and why you're taking it, and what the goals for you are for that medication. Know about side effects and alert your pharmacist doctor if you experience them. And know when to temporarily stop taking a medication, such as if you have the flu or diarrhea, and we'll go over that. And then asking your pharmacist about non-prescription medication and if they're compatible with your kidney disease and current prescriptions. So if you grab something off the shelf, approach the pharmacist, say, I have kidney disease, or my kidney function is this okay for me? And I'm also on these drugs. Learn about different methods to help with adherence. And these could be dosing calendars, dose sets, or blister packaging. And tell all your healthcare team about your medications. Carry with you an up-to-date list in case you can't speak for yourself or can't remember. And ask if there are any tips to improve the effectiveness of your medication, such as eating a low sodium diet, the time of day for dosing, whether you can take it with meals or without, does it matter? And incorporate lifestyle changes to improve your outcome. So water pills or diuretics work best if you are on a low sodium diet, for instance. Here's an example of a medication list, and I just put a red circle around the notes, reason for taking. So everything else is pretty straightforward, but in your own words, why are you taking that medication? So that's quite a good thing to know and to record. This is a little thing that we have on our BC Renal Agency website. It's medication changes when you are sick. So if you're dehydrated from either having the flu or vomiting for a period of time or having diarrhea, if this goes on for a period of time, then you probably should stop taking the medications listed there, and I'll go into that into more detail. But you see, pardon me, water pills, the ACE inhibitor or angiotensin receptor blocker, anti-inflammatories, and if you have stopped taking these for more than 2 days, get in touch with your kidney care clinic team or your doctor or your nurse to let them know that that's what you've done. Another similar version of this in more detail for diabetic patients, this is on the diabetes.ca website for you to download and print if you like, goes more into detail for folks with diabetes. And again, you see a lot of the same medications listed in the blue arrows there. So water pills, certain diabetes pills, what we call the NSAIDs, the ibuprofen, the naproxen, which go under the names of drugs Advil, Motrin, or Aleve, that you can buy without a prescription, that you should not take those. And generally speaking, should not take those if you have kidney disease anyway. So, but you see the ACE inhibitors and ARBs, and they're actually listed there for you. And the SGLT2 inhibitors, canagliflozin, dapagliflozin, and empagliflozin. So in the short term, when you don't, your body's dehydrated, it's safer for your kidneys not to be on these medications. But in the long term, when you're well hydrated, these medications will help your diabetes and help you to delay the progression of kidney disease. So that's just a temporary measure. Sources of drug information. Certainly, the kidney.ca has a wealth of information for you, your physicians, obviously, your pharmacist, your kidney care clinic team, and Google, well, sort of. Make sure you're on reputable sites. So bcrenal.ca, we have good information there. And diabetes.ca is another if you happen to have diabetes. And there's a couple of drug information sources there, but be careful. Some of those might have American information and not represent the Canadian landscape. So are these medicines for me? What should I ask or what should I know? Certainly ask your doctor and pharmacist if there's new medications that might be good for you. Ask your doctor and pharmacist if there are any barriers to getting the medication, such as provincial funding, provincial access, what the landscape is, how much it would cost if you started today. Learn about the new medications and studies. There's great information websites, both locally and nationally, and kidneylink.ca is another one. And ask your doctor if there are any clinical trials that you might be eligible for, because as Adira mentioned, there's an explosion of studies out there that are studying new drugs that you might fit, and understand why you may or may not be able to be in a clinical trial. So there are certain criteria that can be included or excluded from a clinical trial, and just for you to understand why. And with that, I think we'd like to thank you and entertain any questions that you might have.